We almost never get these talks done without the help of lots of other people. So a lot of people helped out, especially Alice Smith and Stephen Goldstein, in addition to Pat Hudgens and John Reese, et cetera. So I have had a lot of help putting this all together. So, no disclaimer. If you see a name on the images, they're from the MedPix teaching file, which is now hosted at NIH. I've got no financial disclosures. I've been through security so many times that they recognize me as I go through there. I like to tell people I'm from the government and I'm here to help. If you're wondering what all these things are on the side, that's how I navigate through my talk, because this talk has 430 slides, which I'm not going to go through, but your handout is relatively inclusive, so there's all kinds of things there. So there's all different kinds of infections. The menu is bacterial, viral, parasitic, fungal, and prions. We know that it's a misfolded protein, but it acts like an infectious agent. You want to remember that bacterial infections can be intracellular, extracellular, interstitial, or in a cavity, like an empyema. Viral infections are usually intracellular, and that's how they cause destruction. They hijack the nuclear DNA, and they take over the machinery in the cell to replicate themselves. So that's where you talk about viral inclusion particles. Fungal infections are usually extracellular, interstitial, or in a cavity like the sinuses, and they're multicellular hyphae. They're too big for macrophages to ingest them, so that's one of the reasons why they're hard to deal with. Parasites, they can be interstitial in a cavity. They can also be intracellular, like toxo and malaria. And prion disease is usually intracellular destruction. So why don't we get infections all the time? We have defensive barriers like the epithelium, bacteriostatic secretions like saliva and tears. It's related to the inoculum size, the virulence of the organism, the competence of the host immunity and defenses, whether it's a new organism or one that we've been previously exposed to, and then we can talk about innate immunity, but we're not an immunology lecture here. The most important thing I can tell you this morning is that infections in the same space are going to look similar regardless of what they are. So if there's anything that I've learned, it's that I can't look at the image and tell you what the organism is. I can look at the image and tell you where I think the inflammation is, but I can't tell you. It requires the knowledge of epidemiology to be able to tell you what the organism is. There are some exceptions. Organism prevalence varies with the patient age, their immune status, and their geographic locale. Basilar meningitis is typically going to be TB and fungal, but there are exceptions to that. Most viruses and prions affect neurons directly, so they're going to be in the gray matter, not in the white matter. And the cortex is a typical location for herpes. The thalamus is a classic location for some of the other encephalitises like West Nile encephalitis, also the location of prion disease like CJD. PML is the exception. Progressive multifocal leukoencephalopathy is an infection of the oligodendrocytes, and it primarily affects them and not the astrocytes. And in immune-suppressed patients, the opportunistic infection prevalence varies geographically. So let's take a look at some of the things that are important. Where is the location? Again, infections in the same space may look similar regardless of the organism. So we have all of these extraaxial locations, epidural, extraaxial in the sense that it's in the ventricle here, subarachnoid space here in a patient with cryptococcosis, in the subdural space here, and then meningeal with enhancement in the subarachnoid space. And then we have intraaxial, so we can have abscesses, we can have parasites here with a little scolex located right there. We can have encephalitis like classic herpes, and then we can have progressive multifocal leukoencephalopathy localized in the white matter. So I could stop with this slide, but I think I have some more things that I'd like to show you. So the extraaxial location, if something is actually in that subdural space, then you can get enhancement in the pachymeninges, the thick meninges on the outside, as well as the leptomeninges, which are the skinny meninges, which is the pia and the arachnoid. I am Greek. I didn't know what pachy and lepto meant until I went to visit my grandparents for the first time when I was 16, and they had a little shrine to my mother's kids there with all of our headshots from elementary school. So they had just the pictures of our heads, in this little cabinet that my grandmother opened up. I walk in the room and she goes, "Pachy, pachy," meaning you're fat. I couldn't tell you were fat from these little headshots that your mother kept sending us from school. So that's how I learned about pachymeningitis. My whole life I've wanted to be lepto. I wanted to be skinny. So I'm not going to do that. But anyway, pachymeningeal enhancement, great lectures we had. Again, you've got this linear thickening here. And also sometimes contrast can get into that fluid-filled space, that hygroma there. So I wonder if sometimes what we're seeing here is not just the meninges enhancing, but actually a thin slips of fluid. Leptomeningeal enhancement is going to get into the sulci. That's a differential feature that you should look for. So here's a patient here that has both subdural and epidural enhancement. Again, you're dissecting the pachymeninges off the inner table of a skull. And again, we got some path correlation there. And this is a patient that did have Pott's puffy tumor. So we know that is going to happen. Again, another case here, subdural empyema. Again, we're displacing the brain away from the inner table of the skull in that space there. We want to remember that in kids, we can get subdural effusions, and that can be very problematic when they have an infection, as well as having a subdural empyema. So in a subdural empyema, we're going to expect to have pachymeningeal enhancement, and the signal of that fluid-filled space is going to be different from CSF, and typically we might have restricted diffusion like you have with pus anywhere else. But if you have a subdural effusion, then you may still have underlying pachymeningeal enhancement, but the diffusion is not going to be restricted. So that's a way that you can tell them apart. So one is, if you will, a neurosurgical emergency. If it's an empyema, one of them is not going to be. So H-flu is the one that we worry about for having the subdural effusion. We've got a case here, a 5-month-old boy. We have this extraaxial collection here. It's probably going to be in the subdural space. We can see it again here on the MR. We can see enhancement all the way around it, and that's very bothersome, seeing enhancement around it, but not really enhancement in the sulci. But in this case here, we want to get to looking at the diffusion-weighted images to see what's going on. And if you have that effusion, it's mostly arachnoid enhancement. If you have restricted diffusion, then it's going to be an empyema. So that's the thing that we're really going to worry about. And again, a lot of statistics there, but we don't need to worry about those this afternoon. So meningitis, classic thing is you're going to have enhancement between the arachnoid and the pia. The contrast is in the subarachnoid space. You may have an abnormally increased flare signal. You should see enhancement in the sulci. It's most commonly going to be bacterial. But it can be, it's most commonly going to be viral, but it can be bacterial. You want to remember that you can also have enhancement in the subarachnoid space after carcinomatous meningitis, but also after hemorrhage. So I want to stop for 1 second to tell you another sidebar story. How many of you have ever remembered treating a patient when you were doing clinical work that had meningitis with intrathecal antibiotics? Anybody ever do that? Okay, so we used to do that occasionally. And the reason why we did that is the patients would always get worse after 8 to 10 days of IV antibiotic therapy. And nobody ever figured out why they were getting worse 8 to 10 days later, but somebody says they're getting worse, blah, blah, blah. So I met a guy who was an ID guy, an infectious disease guy, at a dinner, and we were talking and everything else. And he said, Jim, do you know why the patients always get worse 8 to 10 days after they're getting systemic antibiotic therapy? And I said, no, why? Because you've treated the organism well enough that you've reconstituted the blood-CSF barrier, and the antibiotic is no longer getting into the CSF. And he goes, I know that because we were drawing CSF to look for the levels of the antibiotic in the subarachnoid space. So it's like, wow. Really simple. But what's the point of telling you that in a radiology lecture? Because you're going to see enhancement in the subarachnoid space the same way the antibiotics get into the subarachnoid space, and that is that you have blood-brain barrier breakdown. So if you don't have blood-brain barrier breakdown, you're not going to see contrast enhancement. So what you're going to see is you're going to see contrast filling the sulci because it's in the subarachnoid space, and you're going to see abnormal flare signal, and you're going to see enhancement of the sulci. So that's basically a correlate of that. Now, we have different antibiotics now that probably cross the blood-CSF barrier more. So the organisms vary with the patient's age. CSF sampling is more sensitive than imaging. You know, in this old debate about getting a screening CT before doing a lumbar puncture, we're not going to have that discussion this afternoon. But anyway, you know, part of the issue is that doing a lumbar puncture can give you information that you can't get just from doing the imaging, and it may be complementary to it. So most commonly they're viral, and they're typically not going to be epidemic, but bacterial meningitis can be epidemic. So we have all of these vaccination programs to vaccinate people before they join the military, before they go off to college. And again, the most common is going to be enteroviruses, but measles, influenza, mumps, herpes, any one of these things can cause viral meningitis. So bacterial meningitis, this is where the ID people tell you what the organism is going to be. Newborns get a certain group of infections. Babies and children get a different one. But meningitis, primarily, you want to remember that the CSF is going to be most specific for telling you what it is. The CT, about 2/3 of the patients may have a false negative scan, and the MR, about 1/3 of the patients are going to have a false negative scan in children. So you need to remember that once you've done the imaging, you can tell them it's safe to do an LP, and the LP is going to give them the answer. So old scan here, but contrast in the subarachnoid space, that's what we want to talk about here. You can have a mixture of pachy and leptomeningitis, so it's not always just subarachnoid space, but you can see that, and again, the contrast is in that subarachnoid space. Now, I want to talk about abscesses and cerebritis. So first thing I have to tell you is that if you look at what the pathologists tell us from looking at the tissue, there is an overlap between what's called cerebritis, where you have a disorganized infection, and where you have an organized wall that surrounds pus. And it takes different amounts of time to build that wall depending upon the organism and the patient's responses. So it's kind of a squishy scale between talking about cerebritis and talking about an organized abscess. So if somebody says, is it an abscess or is it cerebritis? If it really looks crisp in the ring of enhancement, then you can say it's probably an organized abscess. If you have a history of when the infection might have started, they had dental work 4 weeks ago, then you're going to say, well, at 4 weeks, it should be an organized abscess. So you want to think about that. And there's going to be surrounding peri-ring vasogenic edema. And again, we tend to look for this hypointensity here, contrasting the pus on the inside and the surrounding vasogenic edema when we have an abscess. Have you all been surprised with patients having big abscesses and relatively few symptoms? I ask the neurosurgeons that all the time. They have no explanation for me why you can have an abscess the size of an orange and the patient is only today coming in with symptoms of headache and fever. I don't know why that happens. It makes absolutely no sense, but that's relatively common that we know that. So how does it get there? We can have direct spread, hematogenous dissemination. It may be from surgery, maybe from trauma. Sometimes no source is identified, which means it probably is bad teeth, but nobody really is carefully looking at what flora are living in those 5 to 8 millimeter pockets around those teeth. But it can be hematogenous, and this is the patient that had vegetation on the valve, IV drug abusers, et cetera, so that stuff that's not supposed to be in the bloodstream gets up there. And again, we talk about this timetable here of early, late cerebritis, when the capsule forms at 2 to 4 weeks. The capsule gets well organized. The infection, if you have a competent immune system, is basically going to be taken care of. Something that I was taught was that you look for daughter abscesses. Hopefully the patient gets diagnosed sooner so they don't get those daughter abscesses. But, you know, classically, we're always screaming about what's the diffusion show? Is there restricted diffusion? There were a lot of arguments about what causes restricted diffusion. People used to talk about viscosity of the stuff that's there. It's probably there's a lot of white cells there, and if you have intracellular water, you have restricted diffusion. So just as a reminder, in acute hematoma, the red cells have restricted diffusion. So this is an OMA of white cells, so it's going to have restricted diffusion. And this is from the same patient RADPath correlation. That pinkish rim there, that's where you have the granulation tissue. That's where you have the proliferating capillaries and fibroblasts. The fibroblasts are going to make the wall about the outside. this is a lot of white cells here, and this patient happened to have a little bit of necrosis in the center. So abscesses are typically round and smooth and regular, but I think we've all seen abscesses that had wavy walls where the distinction with the GBM can be problematic. So, pretty standard abscess here. When I look at this image here, do you see how it looks kind of fuzzy around the outside? Looks kind of like a solar eclipse. So this is probably a patient who is in the very early stages of getting the organized abscess wall, and that's why it's fuzzy on the outside and crisp on the inside. But if you think about a GBM would be fuzzy on the inside and not fuzzy on the outside. So that's another potential differential feature, because when you have necrosis in a GBM, it's oftentimes going to be a shaggy inner wall to the lesion there. So that's that dark rim that we have there. We also look here at this one. This one has a wavy rim around the outside, so that one could be mistaken for a neoplasm, but it has restricted diffusion. Now, if you say, but Jim, have you ever seen a GBM that had restricted diffusion? The center is, yes, I have. But Jim, have you ever seen an abscess that did not have restricted diffusion? The answer is yes. So those things happen, but these are the tools that we have. How many of you have heard of this double rim sign? So, again, this is from the literature here. So the double rim sign, it has a darker outer part and a brighter inner part, just like this little cartoon over here. So that's the double rim sign. So different kinds of abscesses, difference in ring lesions between GBM here that's shaggy all over, shaggy all over, and then if you look here, the GBM doesn't have restricted diffusion. So that's what we look for. Now, complications from an abscess. This might be relevant to perhaps a question that was posed earlier. So abscess complications, mass effect, herniation, daughter abscesses, rupture. Rupture is typically going to go towards the white matter side, get into the ventricle, and give you pyocephalus, not on the outside. If it ruptures into the ventricle, the ependymma gets infected, so it's ependymitis, the choroid gets infected, choroid plexitis, then you can get meningitis, empyema, and osteomyelitis. So just to show you a case here, an abscess ruptured into the ventricle. This is pus in the dependent portion here in the occipital horns, and then there was enhancement of the ependymal wall there. So I want to talk just next about encephalitis and viruses. Remember that a lot of these viruses are in our bodies all the time. They have become dormant. They're minding their own business. And then one day something reactivates the virus, and then you get the infection. So we get exposed to herpes. We have a herpes virus living in the ganglion cells, either dorsal root ganglion for herpes 2 or the trigeminal ganglion for herpes 1. And by the way, the virus chooses which ganglion it wants to live in. So herpes 2, if you get it on your mouth, it's not going to become latent in your Gasserian semilunar trigeminal ganglion. It doesn't like that ganglion. And herpes 1, if you get it someplace else, it's not going to take hold in the dorsal root ganglion. So the virus is tropic for specific kinds of gray matter cells, specific kinds of ganglion cells. So anyway, you're talking basically about a gray matter process, and here we have abnormal signal intensity in the gray matter, and that is going to give you cortical, and so it gets mistaken for other causes of gyral enhancement, which include obviously reperfusion after ischemia, cytotoxic edema after ischemia, or a patient who's post-ictal may have gyral enhancement, and some patients with trauma may get gyral enhancement. And then there's a bunch of those viruses that like infecting the deep gray matter. So you're not going to forget the story about herpes 1 and herpes 2, but remember the viruses have a tropism for certain kinds of neurons. So the virus is choosing which neurons it's going to live in, and that's going to localize where we get the abnormal signal and everything else. So classic case, 21-year-old soldier, deployed to Iraq, found down, my favorite differential diagnosis. They do a scan here, grossly abnormal, the temporal lobe is swollen. Is this gyral enhancement here? Is this sulcal enhancement here? With the swelling gyri, sometimes you get something that mimics subarachnoid hemorrhage when it's not, or mimics enhancement. But this is a patient that has herpes encephalitis. Now, classic herpes encephalitis. So my friends who lecture on infection, they always tell me the following story. The virus is latent in the trigeminal ganglion, and then it jumps into the temporal lobe. And then that's why you end up having the temporal lobe as the most common location for herpes type 1. And it's like, Can I stop for a second and ask you a question? I said, no, Jim, you can't. But no, I'm going to ask you a question. You're telling me the virus is jumping out of a ganglion that's inside of a dural shield, jumps through the subarachnoid space, and it just goes into the uncus because it wants to, and it's nearby? If the virus got in the subarachnoid space, why didn't it go everywhere? And so there may be another answer to that question, which is the root may not be the trigeminal nerve. The root may be the olfactory nerve for the virus, and the olfactory nerve is going to end up going to the uncus. So we don't actually know, but just to tell you two different theories. One theory is it's direct transmission through the dura, of the dural reflection of the cavernous sinus through the subarachnoid space and into the uncus, and the other one is it was lying dormant in the uncus in the first place. So think about that. So I'm getting some smiles here because this is one of those things where you can, get into a fist fight with your best friend over how it spreads. But anyway, temporal lobe, classic appearance here. All the abnormality is in the gray matter. Another differential feature, how do you know it's not an ischemic lesion? It doesn't follow vascular territory pattern. It's in multiple different vascular territories. MCA, PCA supplies the under surface and lateral margin of the temporal lobe. Anterior choroidal artery supplies the area around the uncus, and then you have something on the opposite side as well in the insular cortex. And also sometimes the cingulate gyrus. Some people say about 60% of patients will have involvement of the cingulate gyrus, which is the ACA territory. So it's a non-vascular distribution of cortical gray matter lesions for herpes encephalitis. Now, I need to talk about some other things as we go along, and I want to talk about herpes encephalitis, HIV encephalitis. And again, the spectrum of what you get, AIDS was a lethal disease, now it's a chronic disease. People are taking PrEP, people are taking care of themselves, people are getting diagnosed, less stigmata. But we used to talk about what was HIV encephalitis. So the patients typically would present with the declining mental status or dementia. They would have atrophy that's disproportional to what we would expect for the patient's age. Just as a reminder, HIV is not the only retrovirus. It integrates into our DNA, and that's how it does a lot of its damage to the brain. Something else that I want to remind you is that a significant percentage of all of our human DNA came from retroviruses. So you have to remember that. You have to remember that we all have viral DNA. Some estimates are that up to 10% of human DNA is not human. It's actually from retroviruses that have been incorporated into our DNA. So this is a 42-year-old male, and the brain looks maybe it looks like my brain. So it looks like an older person's brain here with big ventricles and big sulci. But this was a patient that had HIV/AIDS, and they had this atrophic pattern here, primarily involving the periventricular white matter. That's a differential feature for PML, which we'll talk about in just a second, which involves the peripheral and subcortical white matter. So this was a 27-year-old, and this is the autopsy brain for that patient, again showing significant atrophy that's not appropriate for that patient's age. And we can see here that there is inclusion bodies here from a multinucleated giant cell. So anyway, the other thing about HIV arteritis is that you can get infarcts in the basal ganglia from infection of those penetrating vessels that go into the basal ganglia. And again, this is autopsy showing the affected vessels. So HIV vasculopathy is not very common because HIV as AIDS is not as common, but it can occur. Now, let's talk about JCV. How many of you have the John Cunningham virus? I mean, seriously, do you know? Because it's like 70 to 90% of humans living on this planet have the JC virus. We get exposed when we're children. We don't have a clinical infection. And then the virus becomes latent or dormant in parts of our body. And this could also be related to a potential hypothetical question, because there are certain cells that harbor the JC virus, and one of them is the kidney. So the kidney cells, I can assay your urine to find out if you've ever been exposed to JCV, because you may still have JCV there. So again, the prevalence is about 70 to 90%. There was a guy whose paleontologic career went down the toilet about 8 years ago, but he thought he could map human migration by which variant of JCV you had. So he was doing this out of Africa map, looking at the different genomes of the JC virus, and he mapped out where everybody had migrated, and then somebody tapped him on the shoulder and said, this is based on an incorrect assessment of the rate of mutation of the JC virus. The JC virus actually mutates at a different rate from the one you're in your calculation, so your whole thing is just completely wrong because the virus is mutating, and you don't have to have it be 10,000 years away to have a different version in Siberia from what's in Africa. So anyway, that's just an interesting sidebar. I met that guy before he got the tap on the shoulder. He was very unhappy after that. So you have this virus, John Cunningham virus, major HIPAA violation. Well, no, it's not really, because it's already been published in the literature. But the virus was isolated from a patient with Hodgkin's disease who had this bizarre white matter disease, and they got his serum and samples and everything in 1971, and they figured out later on. This is that thing. I can go down to the restroom here and find out that you guys are expressing JC virus in your urine. Don't try to do this at home. But anyway, where is the latency? It's in the genitourinary system, the bone marrow, the tonsils, the lung, the spleen, and the GI, and it may also be dormant in the CNS. But the basic thing is we all have this virus, and then one day it gets woken up, and when it gets woken up, then we have the infection. So what is the characteristic thing about the JC virus? Well, it's a polyoma virus, but the critical thing is it's one of the viruses that likes oligodendrocytes, also astrocytes, but it really likes oligodendrocytes. So the virus has chosen to replicate in the oligodendrocytes, and it's destroying the oligodendrocytes, which make the myelin, so you have demyelination. So you have a pattern of geographic demyelination, and it's called progressive multifocal leukoencephalopathy. Leukoencephalopathy is Greek word, is meaning the white matter is sick. Multifocal, we all know, and progressive because it progresses over time. So you have these geographic lesions in the white matter that progress over time. It used to be uniformly lethal, but just like HIV infection, it can be treated. So patients now may have chronic infection with PML. It may be treated, and the demyelination may stop over time. But the classic appearance is that you have no mass, no enhancement. I liked your 20% rule. So no enhancement except maybe 20%, no mass effect except maybe 20%. For PML, but that's how you're going to diagnose PML. So anyway, you have these peripheral geographic lesions that change over time. And if you want to make the diagnosis, we want to talk about PCR. Now, a couple more things that I saw the yellow light come up, even though I can't see the clock. I want to talk about fungi just for a second, not a second, but a little bit. Fungi are everywhere. They're ubiquitous saprophytes. They're supposed to only eat dead stuff, but sometimes they cheat and they eat living tissue. The ones that we want to worry about are the angioinvasive ones. These have enzymes that digest vessel walls. And this is bread mold, Aspergillus, and mucormycosis, and they cause all of their problems because they do that. So the one that we always talk about is Aspergillus. We think about diabetic patients that have sinusitis, and then you get secondary CNS infection. They invade the vessel wall because they make an elastase that digests the vessel wall. That's why they're angioinvasive. And once they damage the vessel wall, you can get thrombosis and infarction, or you can get rupture and hemorrhage. And so, you have this hyphal form, and then you have this form here where you have the spores, and so you have this thing. So why is it called Aspergillus? And I don't know how religious all of you are, but apparently when you look at the photomicrographs here, you see all of these spores on the outside, and someone said, you know what, this just looks like the aspergillum. It just looks like the aspergillum that the priest uses in church to sprinkle everyone with the holy water. So I have a picture here of Pope Francis causing an Aspergillus outbreak in one of his sermons here. So that's why it's called Aspergillus. But anyway, the thing that you want to remember is this is angioinvasive. It might be spread from the sinuses. It might be hematogenous spread. But you want to expect to see that there might be hemorrhage going along with the infection. And so it doesn't form an abscess like you typically see, but you have the problem of a combination of hemorrhage and infection. So hemorrhage and thrombosis. And just to show you a case here, very significant hemorrhage here in a patient who had disseminated Aspergillus infection. And then just one more, because we know it's common, is to talk, this is going to work for me, toxoplasmosis, an obligate intracellular parasite. The natural reservoir is the common house cat. Everyone's exposed to this. How many of you have cats? Okay, so my daughter is 40 years old, and I have been doing the kitty litter for 41 years, just to let you know, because the bag says pregnant women should not get anywhere near the kitty litter, so it's been the man's job since my daughter was born. So anyway, the bags say that. So, this is a great picture that was shared with me by someone that was in a course I was in, but this is a cat coming out of the wall at the Acropolis, or appearing to very narrow cat. So, crack for the very narrow cat. So toxoplasmosis is, again, an obligate intracellular parasite. It tends to localize in the basal ganglia. It may form an abscess that has a typical shape, but it may have a wavy margin around the outside. You can see here the organisms replicating inside of the cell. There's 4 different ways to get the infection. You can eat the tissue cyst. You can be exposed to dried cat feces. Wouldn't recommend that. It can be transmitted from maternal to fetal, and it can be associated with transplantation. So I just want to summarize what we had a chance to talk about. In terms of meningitis, we want and abscesses, we want to look for the complications. The organism is related to the patient's age and other exposures that they may have had. We want to remember the basic principles, that an infection in the same space looks similar regardless of the organism. The prevalence varies with the immune status, the age of the patient, the geographic locale. Basilar meningitis, I didn't show you examples of TB and fungal, but that's where they tend to go. Most of the viruses are going to affect the gray matter. The exception to that is going to be PML in the oligodendrocytes. And you want to remember about the immune-suppressed patients, the IV drug abusers, et cetera. So extraaxial location, intraaxial location, abscesses point to the ventricle. I want to thank you for your time, and thank you all very, very much.